Okay. Good evening, everyone. Today, the topic of discussion is airway involvement in GPA. First of all, what is GPA? GPA is granulomatosis with polyangiitis. As the name suggests, it is polyangiitis, inflammation of multiple blood vessels with the formation of granuloma in various organs in the body. Formerly, it was known as vaginous granulomatosis, named after a German pathologist, Dr. Frederick Wegener, who described the disease for the first time in 1936. Later, he was found to be associated with Nazis. That's why that term is no longer used to discuss this disease anymore. So basically, GPA is a vasculitis. Vasculitis are broadly classified based on the size of the blood vessels they get involved. It includes large blood vessel vasculitis, medium blood vessel vasculitis, and small blood vessel vasculitis. Small vessel vasculitis are classified again based on presence or absence of ANCA. There are ANCA associated vasculitis and non-ANCA associated vasculitis. ANCA are anti-neutrophilic cytoplasmic antibodies. These are autoantibodies directed against various contents in the neutrophil cytoplasm. So GPA is a ANCA associated small vessel vasculitis. So ANCA vasculitis is potentially lethal form of autoimmune inflammatory disorder. It includes GPA, which was formerly known as vaginous granulomatosis, and also MPA. MPA is microscopic polyangiitis. GPA is a PR3 ANCA vasculitis, which means the autoantibodies are acting against PR3, proteinase 3, which is a content in the neutrophil cytoplasm. The characteristic feature of GPA is necrotizing vasculitis with granuloma. In MPA, it is MPO ANCA vasculitis. Here, the autoantibodies are acting against MPO, myeloperoxidase, in the neutrophil cytoplasm, which is characterized by necrotizing vasculitis, and there won't be any granuloma. So whenever there is a suspicion of ANCA vasculitis, we can have a confusion between GPA and MPA because the clinical presentation can be similar in both the condition. These are the two differentiating features which help us to differentiate between GPA and MPA. The presence or high titer of PR3 ANCA in GPA and granuloma in GPA, whereas in MPA will have MPO ANCA or just necrotizing vasculitis without granuloma. One more entity included in ANCA vasculitis is EGPA, which was formerly known as Chuck-Strauss syndrome. It have a different pathophysiology, clinical feature, and treatment compared with GPA and MPA. And its features are vasculitis, granuloma, asthma, and eosinophilia. So little bit about ANCA. ANCA, there are two types of ANCA, which are P ANCA and C ANCA. This P and C terminology is based on the nuclear staining pattern in electron microscopy. So if we see P ANCA, there is perinuclear staining in this picture. These black things are lobulated nuclei of the neutrophil. In C ANCA, there is cytoplasmic staining pattern, which is a diffuse granular pattern of staining. So C ANCA is a IgG autoantibody acting against PR3, which is proteinase 3 in the neutrophilic cytoplasm, which is specific for vaginous granulomatosis. And P ANCA is again as IgG type of antibodies acting against myeloperoxidase in the neutrophil cytoplasm. But this P ANCA is not specific. It can be seen in other disease also. But when we compare GPA and MPA, the titers for P ANCA will be high in MPA and C ANCA will be high in GPA. So there are some conditions which can cause false positive ANCA. These are other primary autoimmune disorders like autoimmune thyroiditis, like that, and secondary to infections or malignancies, infective endocarditis, inflammatory bowel disease, etc. Whenever there is a persistent high ANCA, even after we are giving optimal vasculitis therapy, we should search for occult malignancies or other autoimmune disorders or other infections or infective endocarditis, like that. Coming to pathogenesis, as like most of the autoimmune diseases, the exact pathogenesis is unknown, but some genetic defects increase the risk of developing vasculitis in some patients, some people. which include a single nucleotide polymorphism of SERPINA1 locus, PTPN22 gene mutation, DPB1, HLA-DQ allele mutations. And there are some environmental triggers has been identified which can result in GPA, development of GPA in genetically predisposed patients, which are mainly Staph aureus infection has been found associated with ANCA-associated vasculitis. Chronic nasal carriage of Staph aureus is a risk factor for relapse of GPA. The other environmental triggers are high intensity exposure to silica, propyl thiouracil, and exposure to levamisole contaminated cocaine. This is a picture, little complex, which explains about the pathophysiology of the GPA. Whenever there is a infection or some initiating event, which can be a combination of environmental risk factors that we discussed in individual which are having a genetic background which increases the risk of developing GPA. This will result the priming of neutrophils. Priming of neutrophil means whenever there is a trigger, the neutrophil will get activated. This PR3 and ANCA, this small red dot which is shown in the cytoplasm of neutrophil represents PR3 or MPO. These are inside the vesicles in neutrophil cytoplasm, which are protected inside the cytoplasm from outside extracellular environment. That is why there is no antibodies against these PR3 or MPO normally. But whenever there is some triggers and the neutrophil get activated, these MPO or PR3 will translocate to the cell surface. Sometimes it will get expelled out to the immediate extracellular environment. So this will trigger the B cells to produce anti-neutrophilic cytoplasmic antibodies against this PR3 and MPO, which will cause the initiation of an inflammatory cascade. It will causes the attraction of other inflammatory cells to the area of inflammation, and also it activates C5a, which is a intermediate of complement pathway, which results in complement activation. All these things will initiate local inflammation and attract other inflammatory cells to the area. And one more pathway is there. There will be increased expansion of T cells. There will be an imbalance between T effector cells and T memory T cells. Increase in effector T cells because of this trigger results in activation of B cells to form plasma cells which can produce ANCA, which are the autoantibodies directed against these neutrophilic cytoplasmic contents like PR3 and MPO. And all these T cells also release several pro-inflammatory cytokines, which acts as a initiator of various inflammatory cascade, which attracts all other inflammatory cells to the site of inflammation. Like monocytes, neutrophils, lymphocytes, everything will get concentrated locally in the area of inflammation. And the circulating monocytes will then transform into tissue residing macrophage, as we see here. These macrophages will initiate the formation of granuloma. And all these inflammatory cells, excess of inflammatory cell, there will be excess concentration of inflammatory cell locally. And when they die off, all these dead materials will form neutrophilic extracellular trap, which acts as a continuous trigger for the further inflammation. That is how the inflammation will get sustained for a long period. So in GPA and also all ANCA vasculitis, there will be multi-system involvement. One of the main clinical or presenting feature can be a constitutional symptoms like generalized tiredness, muscle weakness, joint pains, like that. It can be the presenting symptom even before weeks to months before clinical feature pertaining to the end organ damage. It can involve central nervous system, eyes, ears, heart, kidney, muscle, lungs, airway, GIT, nerves, joints, everywhere. This picture shows the rate of involvement in each organs with each type of ANCA vasculitis. This table shows the clinical manifestations which are related to GPA, which are organ-specific manifestations are given in this picture. We are in today's class, we will be discussing about upper airway and lower airway manifestations. The upper airway, the major clinical or presenting feature will be subglottic or tracheal stenosis, which can present as wheeze or stridor, localized wheeze or stridor, or breathing difficulty. In lower airway, involvement can present like cough, breathlessness, stridor, wheeze, small airway obstruction. In parenchymal, involvement can present like pulmonary nodules, cavitating lesions, then diffuse alveolar hemorrhage because of the alveolar capillaritis, and even they can present like pleural effusion. These are the pictures of some of common manifestations. First one is nasal septal perforation. Second one is depressed nasal bridge causing saddle nose deformity. Third is scleritis, thinning of sclera. This part is what we see is choroid because of the thinned sclera. That is why this color change in the sclera. Then subglottic stenosis, necrotizing skin lesions, and then purpuric rashes in the vasculitis. So GPA is a multi-system disorder, which commonly the usual presentation is a triad of sinusitis, pulmonary infiltrates, and glomerulonephritis. Our interest for today is airway involvement, which is found in around 15 to 55% of patients presenting with GPA. So these are the pulmonary manifestations of GPA. In upper respiratory tract, it can cause nasal disease, sinus disease, ear disease, and oropharynx disease. Nasal disease, nasal crusting, chronic rhinosinusitis, mucosal ulceration, nasal septal perforation, saddle nose deformity. These are the common presentation. In lower respiratory tract, it can involve epiglottis, glottis, larynx, trachea, and bronchial disease. In epiglottis, ulceration, hemorrhage, edema, granuloma. Glottis, the same, ulceration, edema, granuloma. It can cause nodules in the glottis and larynx. Vocal cord involvement can result in hoarseness of voice, loss of voice, stridor, etc. Then stenosis. Tracheal disease, it includes subglottic stenosis and tracheal stenosis. Subglottic stenosis can be simple or complex. Simple means it will be the length of the stenosis will be less than 1 centimeter. In complex, without much airway architectural distortion. In complex stenosis means the length of the stenosis will be more than 1 centimeter and there will be significant architectural distortion. And subglottic stenosis, tracheal stenosis, and bronchial stenosis are the frequent presentation, more common airway manifestations of GPA. Even though we can see all these things, these are not specific for GPA. The common DDs when we see all these things should be EGPA, MPA, sarcoidosis, rheumatoid arthritis, and infections like fungal and mycobacterial infections. So these are the DDs for airway manifestations of GPA. This table shows differential diagnosis of GPA as a whole, like any system. The differential diagnosis include infectious disease like tuberculosis, syphilis, cryptococcal infection, autoimmune disease like IgG4 related disease, multiple sclerosis, neoplastic conditions like lymphoma, meningioma, chemicals like use of chemicals like cocaine, talc, beryllium, other conditions like sarcoidosis, leukodystrophy, like we saw here, this granuloma and cobblestone mucosa in the bronchi. Everything can be seen in sarcoidosis also. So these are the differential diagnoses that we should keep in mind when we deal with GPA. So for a diagnosis, we need clinical evaluation, serological findings, radiological data, and pathology, which will help us to come to the diagnosis of GPA. This is 2022 ACR Euler classification criteria for GPA, which include clinical criteria and laboratory imaging and biopsy criteria. 3 clinical criteria: involvement of nasal cavity, which can present as bloody discharge, ulcers, crusting, cartilaginous involvement like ear and nose cartilage inflammation, endobronchial involvement, saddle nose deformity, then conductive or sensory neural hearing loss. These are the clinical criteria. The next column shows the positive points that we can give to if at all these features are present. Then laboratory criteria like positive C ANCA, pulmonary nodules, cavitating chest lesions, granulomas, giant cells in biopsy, inflammation, consolidation, all the features that we saw, clinical features that we saw with the lung involvement, and pauci-immune glomerulonephritis on biopsy. When if we see the clinical classification, this involvement of lung and involvement of lung and involvement of kidney are mainly important while diagnosing GPA. And there are two things that are negative for GPA: the presence of P ANCA and blood eosinophils. P ANCA suggests more towards MPA, and blood eosinophils suggest more towards EGPA. So whenever the point is more than or equal to 5, then we can classify the disease the patient is having as GPA. This picture shows all the imaging findings, the more common imaging findings that we can see in lung involvement in GPA. One is nodules, 2 nodules with the peripheral halo, which is a halo sign, 3 cavitating nodule, 4A is ground glass opacity. Ground glass opacity, the pathology behind ground glass opacity is whenever there is a partial displacement of air from the alveoli, that is what we see as a ground glass opacity in imaging. Here the inflammatory exudate will partially displace the air in the alveoli, and which we see as ground glass opacity in the CT. Then 4B consolidation, 4C thickening of the bronchi, 5 is tracheal stenosis, 6 is pleural effusion. These are the common imaging pulmonary manifestations of GPA. So the airway management includes, here the first picture we can see there is a central airway involvement with narrowing of the left bronchus, this leading to a left lung collapse due to chronic involvement of the left main bronchus. The second picture also shows circumferential thickening, submucosal thickening of the trachea, which can be seen in the sagittal image also, this narrowing in the trachea. So other investigations, this is a table showing other investigations. These are specific to the organ of involvement. I'm not going into each one. Inflammatory markers like CRP, ESR, and then kidney function, immunology, like that. This also imaging of CT thorax if we are suspecting, if in case of lung involvement, ultrasound abdomen to rule out kidney involvement, echocardiography to rule out heart. And if at all we are suspecting infective endocarditis, because it can mimic ANCA vasculitis, as infective endocarditis can also show a raised C and P ANCA titer. Then coming to lung functions, lung function testing spirometry. Spirometry can cause change in flow volume loop because of the bronchial or tracheal stenosis. It can cause a change in flow volume loop that we will discuss in the next slides. And if at all there is a critical narrowing of the airway and airway, which is leading to collapse of the lung or lobes, it can lead to reduced lung volumes in spirometry. And DLCO can be reduced due to the inflammation of the perivascular inflammation, which hinders the transmission, diffusion of gases. It results in reduction in DLCO. But DLCO can be increased, markedly increased, if at all there is a presence of diffuse alveolar hemorrhage due to alveolar capillaritis in GPA. So the clinical manifestations like vocal cord dysfunction, laryngeal or tracheal malacia, laryngomalacia, or any tumor or mass-like lesions, granulomatous mass-like lesions, or early subglottic stenosis, that is inflammatory stenosis. All these things can cause variable extrathoracic obstructions, which can result in spirometry with the flattening of the inspiratory loop. And whenever subglottic stenosis is chronic and it is more of fibrotic rather than a inflammatory change, or in not in active stage, it can cause fixed airway obstruction, which can result in flattening of both inspiratory and expiratory loops in the spirometry. And intrathoracic tracheal stenosis, when it can cause variable intrathoracic obstruction in the early stage or fixed airway obstruction. If it is intrathoracic, then there will be truncation or the flattening of the expiratory loop in spirometry. And if at all there is a bronchial stenosis, since isolated bronchial stenosis, it can result in differential emptying and filling of the lungs, which results in formation of double S shaped loop in spirometry. So spirometry can also can be a clue to our diagnosis, not to a GPA, but in airway stenosis. So our point of interest today is airway involvement. So what are the bronchoscopic features? Bronchoscopic features can be a subglottic stenosis or complex tracheal stenosis. Third picture is the vocal cord involvement in GPA. We can see the complete destruction of vocal cords due to the vasculitis. So the mucosal abnormalities can be a cobblestone appearance, likewise in sarcoidosis, or it can be erythematous and friable mucosa like the second picture, or it can be a mucosal plaque. Or there can be mucosal ulcers, hypertrophic tissues. These hypertrophic tissues can later get epithelialized and can form submucosal bridges like in the third picture. There can be excessive crusting because of the inflammation can result in more purulent secretions in the airway, and which can result in crusting later on and can be seen in bronchoscopy like this. And another feature that can be seen is bronchomalacia. This picture shows bronchomalacia of bronchus intermedius. So whenever we are seeing all these lesions, as we already said, these are not specific to GPA. There are many other differentials. We have to go for biopsy. Biopsy, like we can go for forceps biopsy, cryobiopsy, or if at all the lesion is around the airway, we can go for rebus and needle aspiration to get the tissue and look for granuloma and necrotizing vasculitis. In the management, mostly all the lesions that we saw in the previous slides are part of active GPAs that will get subsided with systemic management, that is immunosuppression for the GPA. But we have to go for a bronchoscopic management in some airway involvement, especially when there is a tracheal or bronchial stenosis. We can use various sized rigid bronchoscope or tracheoscope or tracheal dilators for blunt dilatation of the stenotic areas. And rigid bronchoscopically, we can it will help us to treat the stenosis with stenting. So this bottom picture shows a pre-procedure airway, narrowed airway, and post-procedure airway with a silicone stent. The distal end of the rigid bronchoscope is beveled and can be used for used as a coring device whenever there is a mass lesion, small mass lesions, or subglottic bridging like that. We can use it as a coring device. And another treatment management that we can do through bronchoscopy is corticosteroid injection, local corticosteroid injection in the inflamed area just underneath the mucosa, which help us to control the inflammation with locally with local steroids. And whenever there is a mucosal narrowing, the narrowing of airway is not involved with cartilage, we can go for balloon dilatation. Balloon dilatation will be helpful when the soft tissue causes the narrowing of the airway. We can go for CRE balloon for the dilatation of the airway. But whenever the cartilage is involved, balloon dilatation will not give a much result. In that cases, we have to go for laser or electrosurgery, electrocautery knife. Laser, we can use CO2 laser is the preferred laser for treating benign stenosis. There won't be any scattering or no deep penetration. So the risk for collateral mucosal damage and airway perforation is low with laser. But laser is costly and more riskier. In that case, we can use electrocautery knife for the endoscopic management, especially for web-like benign stenosis, which include which have a cartilaginous distortion and all, which this electrocautery knife work by contact and can easily cut through the tracheal or bronchial wall and cartilage with radial incisions. Cost of the equipment of electrosurgery is cheaper compared with lasers, and it offers more precise and limited tissue vaporization than laser. This is a summary of medical management of GPA, which is 2021 ACR or vasculitis foundation guidelines, which is mostly done by rheumatologists. There are two phases of treatment. First one is induction of remission, and then the maintenance. Induction in severe GPA, we have to use glucocorticoids IV or high oral glucocorticoids along with rituximab. Previously, it was cyclophosphamide. Now the guidelines suggest to use rituximab because of higher side effect profile of cyclophosphamide. Once the remission induction is done, we can use rituximab, methotrexate, or MMF for the maintenance of the remission. In non-severe GPA, for induction of remission, we use glucocorticoids plus methotrexate. There is no need for higher immunosuppressions like rituximab or cyclophosphamide in non-severe GPA. Non-severe GPA means there should not be any end organ damage. So this table shows the dosages of each drugs that we use for medical management. This table shows the newer targeted therapies under trial for GPA. It shows the mechanism of each drugs also in this table. I'm not explaining this in detail. So the take home points are it is GPA is a potentially lethal, hence missing can kill the patient, and multi-system involvement we have to look for other system involvement, and because multi-system involvement is the clue to diagnosis for any vasculitis, as this is a systemic disease. And medical management is mostly by rheumatologists. Our role is mainly in the airway interventions. First of all, the diagnosis via biopsy if at all there is an airway lesion, and also airway interventions in case of airway stenosis, which can be done for symptomatic relief. At times it can be life saving. Thank you.